everybody. Welcome back to Pelvis Party. My name is Becky Monpetit. I'm the owner of Rochester Local, and here are my lovely guests today. This is Dr. Melissa Richards. She is the division chair of hospital and surgical services at Olmsted Medical Center. And this is Carrie Rochester. She is a certified nurse midwife and a certified sexual health counselor. And today we're going to continue our talk about sex.
Right?
Right?
We might as well just keep rolling this.
I know. So this is our third episode with Carrie because it's so important and so fascinating. We've talked about the fact that there is sexual health counseling and services at Olmsted Medical Center. We have talked about pain during sex. That was our last episode. And now we want to talk about pelvic pain, just in general. Not pain during sex, pelvic pain. And this is really adjacent to what you do and how you help the patients that you see. So let's dive into this topic of pelvic pain. It's kind of like a huge topic,
Right.
right?
It is. It is enormous. So when we talk about pelvic pain, when I have a conversation with a patient, I get a little overwhelmed because typically it's not something that happened yesterday. It's chronic pain. So this has been going on for quite some time. So we get their history, we talk through things, and then it's been my experience, and I think, Carrie, you would agree, people just want information. They want to make it make sense. So pelvic pain, I start out with explaining what are the different types of pelvic pain? What are the different causes of pelvic pain? So I'll say it's my fault. So it's a gynecologic reason, whether it's endometriosis, ovarian cysts that are quite symptomatic, vaginal dryness, something that's happened in the past that has continued to be an issue when it from a gynecologic issue like infection. And then there's the gut. So irritable bowel syndrome, colitis. Then there's your bladder. So interstitial cystitis.
Oh,
I know that's a big one.
Yeah.
Chronic urinary tract infections. And then whether it's gynecologic, gastrointestinal, your gut, urologic, bladder system, there's always, in my opinion, a musculoskeletal component to this. The muscles in your abdomen, your lower abdomen, and the muscles in your pelvis, their job is to protect you. And when there's trauma happening inside the abdomen for whatever reason, like in the pelvis, those muscles are going to react and they learn things. So whenever we have this conversation, we get to a point where we're like, okay, we figured out what we think is going on. It's a genital urinary syndrome of menopause, so dry vagina, or endometriosis. We fix the primary issue. We work on that. But I counsel heavily that there likely is a musculoskeletal component to this. So we have to keep our heart open to the idea of pelvic floor physical therapy to retrain those muscles like this is a safe place. This is a safe place. And when you have that initial conversation where you kind of explain the different categories and explain how we're going to get through it all, people just go from being very almost standoffish because they've brought up their pelvic pain in the past and it feels like nothing's being addressed to like, oh my gosh, this makes sense. And now we can work through things because I often also, I think, Carrie, you would agree, you feel like you're on this person's been on this journey for quite some time, oftentimes years. And then you're joining right here. And they're taking a risk. I just recently saw a patient who said, I swore off seeing doctors because I have pelvic pain. I know I have endometriosis. We did a hysterectomy and I'm still having pain issues. And I was told, like, I basically have to deal with it. It's endo. You're going to have to deal with it. And that was, the clinician, I don't think knew that was how it was interpreted. But just having that moment to walk through with the patient to say, like, did anyone talk to you about musculoskeletal causes? Did anyone talk about endo can come back? Endometriosis, slang, endo.
Gotcha.
Like, so much of it is talking, and you see this theme here with Pelvis Party, normalizing, and then making a plan, trying to meet the expectations of what the patient would like to experience.
And I'm sure you feel the same way. And sometimes they don't always have this expectation that you're going to fix them. Sometimes they just want to be heard because they've been brushed off for so long.
Yep.
Like, there's so much data about
Mhm.
how healthcare providers minimize women's pain.
Mhm.
And so sometimes it's really just about being heard,
Yeah.
that there isn't like, oh my God, this doctor's going to fix me.
Right.
Right.
They just want to feel
They
heard.
just
Right.
want to be heard, and like my experience is valid, and it's hard because I think that there's this understanding that when we go to the doctor, what they say is the authority, and if they say, "Well, deal with it," then that puts you in a place where why would you talk about it with anybody
What
else?
I think is interesting is what you just said. The clinician said, "Just deal with it." I've never heard a clinician, and maybe they're out there, I'm sure, say, "Just deal with it."
Yeah.
But what I'm saying, my
Yes.
intent and the
Mhm.
perception are two
Mhm.
different things,
It's
Yep.
right?
exactly
It's
Yep.
right.
not
Yep.
uncommon for that to happen.
Yeah.
So, once again, feeling like you can advocate for yourself either
Yes.
with that clinician or maybe we need a different perspective.
Mhm.
Ask those probing questions about, like, okay, what I'm hearing from you, Dr. Richards, is my only options are this and this.
Yep.
Yes, those are your two options, or
Yeah.
these are your three options. However,
Yeah.
we can try this, try that. I've also taken a lot of pressure off myself to get it right. And I
Mhm.
vocalize that to the
Yeah.
patient. Say, I will literally say, I have learned to take pressure off myself and you. We are seeing each other for a 30-minute visit. There is
Mhm.
a very good chance that the first thing that we try to make your pelvic pain better may not work or meet the
Yeah.
expectations that you have.
Yeah.
Let's not put pressure on ourselves to get it right the
Right.
first
Mhm.
time. Maybe
Right.
there's side
Mhm.
effects that you don't like
Right.
about it. Maybe,
Mhm.
we think it's this, but really it's this. That first visit is a lot of, in my opinion, should be education. And then with your pelvic pain patients, I oftentimes will talk about doing an exam
Mhm.
because a lot of people, we like to blame our ovaries
Mhm.
and we like to blame endometriosis.
Uh-huh.
Um, and in many cases, that might be the diagnosis that's
Right.
causing pain.
Right.
But I find it is not uncommon after a pelvic exam, and I'm like, this is your levator ani muscles. And they're like, woo, that's my pain. Or
Oh.
this is
Yeah.
your obturator internus muscles. Oh my gosh.
Mhm.
That, as I said, that musculoskeletal component is just so huge in pelvic pain.
Yeah.
Um, but there can be sinister things, also naughty things that cause pelvic pain.
Yeah.
So it's not uncommon for me to get a pelvic ultrasound. That is kind of our, from a gynecologic
Mhm.
standpoint, our
Mhm.
go-to for imaging
Mhm.
to
Yeah.
look at your pelvic organs.
Mhm.
Um, and then it's an ongoing process
Right.
of trying to figure out what is causing the pain,
Mhm.
and then sometimes we treat right away without a diagnosis,
Mhm.
and that kind of sounds a little weird. There are a lot of things in women's health that a certain treatment like hormones,
Sure.
non-steroidal anti-inflammatory
Yep. Yep.
medications, treat multiple things.
Yeah.
Now, in my opinion, I think, and Carrie, I think you'd agree with that. That's kind of a disappointing answer in my
Oh.
opinion. So as we get more information about and we learn more and there's more research into pelvic pain, we're going to have better answers
Mhm.
and better treatment modalities. But until we have that, some of our treatment, we're doing the best we can with what we
Right.
have, right?
Right.
Sure. Sure. So, one of the hot button words that you mentioned that I think is worth us
Hmm.
talking about a little bit is
Hmm.
endometriosis. Um, it is this condition
Hmm.
that a lot of women can have, but it can also be misdiagnosed or not diagnosed altogether.
Mhm.
And sometimes it's really easy to diagnose it, and other times it goes years and years and years without
Mhm.
diagnosing it. So it's just like this mystery. Can
Mhm.
we talk about that? Because that's a major contributor to people who have pelvic pain,
Hmm.
or it can be.
Hmm.
Mhm.
We know that up to, the numbers are kind of all over the place,
Yeah.
but 10% of women or
Mm-hmm.
people with uteruses in the world have some sign of endometriosis.
Okay.
Um, those numbers are probably not that great. There's
Mm-hmm.
probably some play to that because really the way you diagnose endometriosis is through laparoscopy typically,
Mhm.
or
Yeah.
actually having a biopsy proven spot of endometriosis. Endometriosis, the tissue that we're talking about, looks like the tissue that's inside the lining of the uterus that we shed with our
Yes.
periods.
Yes. Okay.
We There's a lot of theories as to where this tissue comes from.
Okay.
So retrograde menstruation, which just like
Uh-huh.
cracks me up. The idea that perhaps this tissue is leaving through your fallopian tubes and implanting inside your belly.
Mhm.
So these like
Um,
little areas of the same, it's not the same. So that's the
yes.
trick is the tissue that we're calling endometriosis. We used to say like it's the same as the tissue inside your uterus. It's not. It's different.
It's different.
It's
Mhm.
different. But that retrograde menstruation story gets blown out of the water because we've had patients who have it in their lungs. So how did that
Endometriosis in your lungs.
hip joints, brain,
What?
endometriosis can be in different places. Like those are, I know.
What?
Exactly. Those are a
Oh,
lot of case reports. But even myself, I've had a patient who we had every time she get her period, she would cough blood from her endo and her, yeah, I know, right?
women.
Exactly.
Poor
Exactly.
us.
Exactly. Exactly. So what worked well for her is we had her on Depo-Provera, a medication that helps suppress um, the ability of that tissue to grow. So she wouldn't get a period, but she also didn't cough blood. Um,
Oh my
I know,
stars. Like
wild.
my
Mhm.
mind is completely blown with that story, but all the more reason to do this research into
Mm-hmm.
this endometriosis and talk with your provider
Mm-hmm.
about this pelvic pain.
Mm-hmm.
Um, because sure, there's a lot more research that can be done, but there's also a lot that can be done to help treat. And that's, I think, kind of where you tie hand in hand with
Mm-hmm.
the sexual health counseling
Mhm.
that you do. Maybe they're having pain during sex. Maybe there's discomfort. Maybe there's loss.
Which can be caused by
Is exactly
endometriosis.
Mhm.
right.
Yep.
And so it's you're tying hand in hand.
Mm-hmm.
Um, so you'll hear a lot of people maybe, and this is I'm contextualizing and
Mm-hmm.
grouping in, but people will say, oh, I think that's just endometriosis, or they'll self-diagnose. What would be the first symptom or cause to maybe clue somebody in, like, oh, something's not right here? What
Yep.
something's not right here?
So pelvic pain.
Mhm.
It
Mm-hmm.
usually presents in your even your teen years into your 20s and 30s. Cyclical pain,
Mhm.
meaning really with your periods. That's when it really likes to flare
Sure.
because we think part of this is you have the endometriosis, these little implants of tissue, and your
Mm-hmm.
body when you get your period, the response of that tissue doing what it's doing, your body's like, this is not normal. This is not normal. This tissue should not be growing inside your belly. So then you
Yeah.
have an
Mhm.
inflammatory response and can
Uh-huh.
cause issues with scarring inside the belly.
Sure.
So going back to like symptoms, painful periods.
Yeah.
Some people notice like bowel movement issues.
Oh,
Mhm.
Some
okay.
people because it can affect the bowel,
Sure.
even blood in your poop sometimes.
Mhm.
Mm.
Um, Sometimes people will have like fertility issues.
Yeah.
So we'll, as part of a fertility workup, we'll diagnose endometriosis. Endo is also really interesting because you'll be doing, sometimes I'll have a patient who has really heavy periods and we've tried a bunch of stuff, it doesn't work, and we end up doing a hysterectomy and or removing the uterus, not the ovaries.
Yep.
But remember, hysterectomy
Y-
is removing uterus,
Yes. Mm-hmm.
oophorectomy, removing ovaries.
Ovaries. Yes, I
hmm
got it.
And you go in and you start this, and you're like, holy smokes, there's endometriosis all over the
Yeah.
place. Patient had no symptoms. They're like, so some people
Yeah.
have none. And then you'll have a patient who's had chronic cyclical pain for the last 5 years. We have tried doing some hormonal management. We've tried some like NSAIDs.
Mm-hmm.
And we're like, it's time to do a diagnostic laparoscopy, a little incision in the belly button, look around, and you'll see there's this little tiny bit of endo. And you remove that endometriosis. You
Mm-hmm.
treat anything that you can see. After surgery, we talk about subsequent treatment of that endometriosis, and they feel better. And you're like, oh my gosh, oh my goodness,
Bodies are
wild.
wild, unhinged, and amazing.
And it is not uncommon. It's just the power of the mind and body. Patient thinks, I have endo, I have endo, I think I have endo. We do a laparoscopy, we look inside the belly, we don't see any endo. We don't see zero, no endo at all. Close up, we're done with surgery. You see them 2 weeks later and they say, Dr. Richards, I feel so much better. Because I think there's also that component of something bad is going on in my
Something.
pelvis.
Yep.
Mhm.
Something bad is happening.
Yep.
And by having that Now, to be clear, I don't want to start like a diagnostic laparoscopy service where I'm
Yeah.
sneaking
Mhm.
peeks into people's bellies all the time
Yeah.
because that is a surgery. I'm purposefully hurting you.
Yes.
So we want to make sure when we take people to the operating room, we have good reasons to do that. But there is something really amazing that can happen just knowing after years of pelvic pain that there isn't endometriosis. And maybe this is, a lot of this is musculoskeletal. So let's focus on the musculoskeletal component, or let's look at
Right.
other causes. Oh my gosh, you have IBS. Let's treat your IBS,
Oh,
right?
geez. Yeah.
A lot of people think they have endometriosis who probably have endometriosis, and a lot of people think that they have endometriosis and they don't have endometriosis.
So so what you're saying is it's really easy to sort out. Yeah,
Yeah,
no,
super
not at all.
easy.
So all the more reason to advocate for yourself in the your provider's room, and to ask those hard questions. And if you're unclear about something, ask a follow-up question, because that's their
Hmm.
responsibility, that's their role. And even they don't have all the answers to this
Hmm.
mystery.
Hmm.
But starting there is the best thing that you can do. And what we say here all the time on pelvis parties: don't
Mm-mm.
settle. If you have pain, don't settle. There are things that can be done.
And this is why I'm so proud to work at the organization that I do work at. At Olmsted Medical Center, we really listen to what our patients need. We have expanded services,
Mm-hmm.
and this is just a great example of working together as a team.
Yep.
Um, I think all of our clinicians are fantastic and
Mhm.
can create these relationships with patients,
Right.
Mhm.
recognizing that not everyone's going to be a perfect fit with their clinician.
Right.
But I think I would bet a solid $100,
One
which is
hundred
like a
dollars. Yes.
huge bet for me,
Yeah.
that there is a clinician at Olmsted Medical Center there for every person out there that would
Mm-hmm.
be a good fit, that you can feel comfortable
Yeah.
with and get really good care.
Mm-hmm.
And if that person doesn't have the answers, they're going to help facilitate
Yes.
that
Mhm.
experience to get to where you need to get to.
Yes.
I'll never forget when Missy interviewed me.
That's me.
Yes. Oh, sorry, Dr.
It's
Richards.
fine.
No, I
It's
love
fine.
it.
I
Sorry.
love it.
Yeah.
It's great. It's
Mm-hmm.
perfect.
The first thing she said to me, because I worked at another larger
Uh-huh.
organization, is all patients that come to OMC choose
Yep.
to come to OMC.
Mhm.
Mm-hmm.
And like I've really seen that
Yep.
since I've started with
Yep.
the organization.
It's special.
And I love that perspective. And, bouncing off of what you're saying, is just this team approach to a person's health. There's no one who is trying to, keep a patient to themselves for whatever reason that might be. It's just this team approach. So, sexual health, pelvic floor therapy, OBGYN, all very closely working together to solve problems, to come up with treatments, to provide hope,
Mhm.
right?
Mhm.
And I've experienced that myself, so it's a really special part of OMC. But, anyways, Missy and Carrie,
Love it.
thank you so much
Perfect.
for joining us
That's
on
perfect.
Pelvis Party today. And if you're interested in more episodes about pelvis party, pelvic pain, these sorts of things, visit rochesterlocal.com/pelvis party.